The Move, Look, and Listen podcast with Dr. Doug Stephey is brought to you by Audible. Get a free audiobook download and a 30-day free trial Audible membership at audibletrial.com/inbound. You'll find over 180,000 titles to choose from, including several books mentioned here in the podcast. Support the Move, Look, and Listen podcast by visiting audibletrial.com/inbound.
If our two eyes are not working together well as a fast, synchronized team, our internal mapquest continues to be off. It's consistently inconsistent with our ability to judge time and space. Those that don't feel well grounded, those that have some measure of anxiety, oftentimes it starts in the visual system. If you can't move, look, and listen in a fast, accurate, effortless, sustainable, age-appropriate, meaningful way, you're in a world of hurt. There's a whole world in vision and how it affects brain function that no one's ever shared with you. 2020 is perceived as the holy grail of going to the eye doctor. Well, I'm here to change that paradigm.
This is the Move, Look, and Listen podcast with Dr. Doug Stephey. I'm Tim Edwards with the Inbound Podcasting Network and a patient of Dr. Stephey's. And we appreciate you tuning into the podcast today. We know when you hear the term or the word or the profession optometrist, you think, I'm going to go get some glasses, get some contacts, and be on my way. And that's traditionally what happens when you go see an optometrist. Well, if you listen to some of our previous episodes, you know that I have a video production marketing company, and I have interviewed dozens of optometrists here in the Southern California area. But there was this one day that I produced a video for Dr. Doug Stephey in Covina, California, that changed the way I thought of optometrists, or at least this one in particular, because Dr. Stephey was the first optometrist that told me about vision therapy, not just how I could see 20/20. Now, Dr. Stephey, we have touched on vision therapy in previous episodes, and you talked a little bit about what it entails, but let's just dedicate an entire episode to vision therapy because future podcasts will depend upon the information we present today.
Tim, I think it's a wonderful idea, and there is a lot of information and misinformation about vision therapy and what it is and what it does. So one of the first myths that I want to talk about is when somebody says, well, I heard vision therapy doesn't work. And I say, doesn't work to do what? And then they say, what do you mean? And I say, what do you mean? You're the one that said vision therapy doesn't work. I'm asking you, doesn't work to do what? And then they pause again. And then I say, jokingly, well, does vision therapy cure world hunger? No, vision therapy doesn't work to do that. And then we have a chuckle about that because that seems so preposterous, right?
Right.
But it opens a discussion to talk about what vision therapy does and doesn't do. For example, there are components within medicine and education that put out the argument there is no proof that vision therapy cures dyslexia. Therefore, vision therapy doesn't work. Well, that's a heck of a statement and conclusion.
Mm-hmm.
I don't really know of any optometrist doing vision therapy that would make the claim that vision therapy cures dyslexia.
That vision therapy or even glasses cures anything.
Well, that's my point.
I mean,
so when the false premise is written by others that want to denigrate vision therapy, that vision therapy, there's no evidence that vision therapy cures dyslexia, therefore vision therapy doesn't work, and make a global blanket statement, right? That's the classic, you set up a straw man's argument and then argue the false premise. It's just wrong, and it's disingenuous at best. So does vision therapy cure dyslexia? I would make the argument that no, vision therapy doesn't cure dyslexia. But we're back to the issue of what is vision therapy and what is it designed to do? Well, that's a really wonderfully complex and loaded question.
But for those like me who never heard of vision therapy before, what is it?
Right. What is it? So when I have that exact same conversation in the practice, and I've got a limited amount of time to do it, kind of like doing this podcast, it goes something like this. I said, imagine a 3-circle Venn diagram One circle is, can you see 20/20? The second circle is, are your eyes healthy? And that's where most eye doctors practice, optometry and ophthalmology alike, in those two circles. You can have an exam like that and be told everything is fine, and you could still have a profound vision therapy problem because that exists in the third circle. It's like the third rail at the subway, right? The third rail. Mm-hmm. Well, in this case, that third circle, in it, it has items like this: retained primitive reflexes, magnocellular vision deficits, visual aliasing and visual stress, convergence and facility, accommodative infacility, accommodative dysfunction, motor planning and sequencing deficits, working memory and executive function issues, rapid naming skills deficits, even phonological processing deficits, and even some auditory processing outcomes are affected by visual skills.
Okay, but I got to interrupt you because these are really cool sounding terms.
I know.
But someone like me is like, I don't know what that is.
And ultimately, that's really my point to start with. My point is that when I list those terms off and it sounds like I'm talking a foreign language, that's really my point. Because I say, anything that I just said, does it sound like it's related to seeing 20/20 letters on a night chart at 20 feet? And then patients are like, well, no, I never heard of those things before. I'm like, that's my point. There's a whole world in vision and how it affects brain function that no one's ever shared with you. So in that context, and in a simpler version of things, vision and auditory are our primary threat detectors. It's the primary sensory modality of how we interact with the world around us, both in us asking ourselves the question subconsciously, do we feel safe? And do we have the visual skills to know where we are in space, to be well grounded? And that goes to our sense of ego and our sense of self and how we fit in this world. We also use vision to read gestural language and facial expressions. And I would argue that most social psychologists would make the argument that 80% of how we communicate is done through body language, not through the words that come out of our mouth. There was a show called Lie to Me that was about reading body language. And remember, reading body language isn't through touch or auditory, it's happening through vision. So there's a number of skills, like the terminology I rattled off a few minutes ago, that people don't know about. So my job as a neurodevelopmental optometrist is to figure out, do you have such a problem? And what areas might it lie in? And how does it show up in your day-to-day life? Whether you have issues with driving at dusk or nighttime, or I have some patients that avoid driving the freeway. I can't do it. It's too anxiety producing.
I know several people that won't drive on the freeway, period.
That's a vision problem, because driving at freeway speeds is about using your visual skills to judge the movement of time and space. And the faster the speed, the less time and space that you have in order to make that judgment. So people avoid it. I have other people that don't drive in the carpool lane. The concrete dividers whizzing past their peripheral vision acts like a magnet on their visual attention. And in some patients, their car feels like it's demonized and wants to drive itself into the wall. So these vision therapy related skills and the deficits within those skills affect every aspect of our lives. I don't care if you're a baby learning speech or you're 90 years old wanting to keep your driver's license or not trip and fall and break something and then never recover from the broken bone. All this ties into these visual skills. So in my estimation, the biggest challenge is doing the right assessment to start with. So you know all the pieces within that third circle of the Venn diagram so that you can then create a developmental hierarchy to what should we treat first and second and third. Much like the expression, you got to walk before you run. Well, you got to crawl before you walk, and you've got to roll over before you get up on all fours. And before you can roll over, you got to be able to lift your head off the floor. You got to be able to push yourself up with your arms. You got to know that your arms and legs even belong to you and that you have some voluntary control over them. That's all a developmental hierarchy. And it ties in to the whole theme of my practice in this podcast, which is move, look, and listen.
Dr. Stephey, not looking for an exact number here, but maybe more of a ballpark figure. If someone hears the term like myself, vision therapy, my first thought would be, well, that's probably a very small percentage of the population that needs something like that because of the word therapy, right? But in your estimation, over your 30 years of being in practice, I'm sure that number's pretty high. What percentage of your patients you think could benefit from vision therapy?
I think the more general question is, what about the population at large, not just about my population?
Absolutely,
right?
Sure.
So 10 to 20% of the population at large likely has a vision-related deficit that they know nothing about because it falls in the third circle that's never been assessed. But again, just generally speaking, if we look at different subcategories in the population, autism, ADD, ADHD, working memory, executive dysfunction, reading disability, dyslexia, learning disorder, bipolar, schizophrenia, motion sickness, migraine, chronic headache, fatigue, pick one.
Yeah, that's a lot of people.
That's a lot of people.
That's a lot of people.
It is estimated today that 1 out of, I think, every 68 kids born today is getting a diagnosis of autism.
Wow.
By 2030, it's speculated 1 out of every 3 kids. And a retired psychiatrist that I know who's been to some continuing education says that where she's gone to, the speculation is that by 2050, there'll be no neurotypical kids left.
Well, that's a whole other podcast because in the Inbound Podcasting Network, we have other clients that talk about what they believe are the reasons for that increase. We don't need to get into that right now, but
That's right.
But there are hard numbers, true data to support what you just said.
Yep. So let's circle back to what is vision therapy then? The simplest explanation is that vision therapy is like physical therapy on the eyes and brain. Some people mistakenly think that vision therapy is something that we're doing that makes your eye muscles stronger. That is not the case. It's never a question, or it's rarely ever a question, that your eye muscles are quote unquote weak. What's more significant is how your brain tells those muscles what to do. So there's certain neural networks that control these skills: visual attention, visual processing speed, in lay terms, eye focusing, eye teaming, eye tracking, visual spatial skills, visual auditory integration, visual motor skills, visual cognitive abilities. Again, each of those different categories has therapy tied to each of those singular items. But globally, it's changing the way your brain tells your eyes what to do, and it changes the way your brain processes visual data. So there's a sensory component of how you take in visual information. There's an integrative component that's happening in your mind about how you process and assimilate that data in preparation for acting upon that data, usually through some sort of motor output, either with speech and language, or that I've got to move from point A to point B, or I've got to throw a ball from third base to first base, or that I've got to parallel park a car and not hit the car in front of me or behind me. So you get the idea that vision's pretty pervasive in every waking second of every day. So vision therapy is not making your eye muscles stronger. It's changing the way your brain processes visual input. That's the most simplest of explanations. And then there's a couple different models of the delivery of that care. There are models that would propose to really never, and the absolutes of never and always. You always going to want to stay from absolutes.
Always. I think we understand, but you're right. I know, and I'm guilty.
So one camp would say you need to do free space activities that do not involve a computer screen and that involve whole body component in the eye movement activities. So it's a whole body eye movement experience. And there's value in that. There was a pediatrician from Yale, I believe, named Arnold Gesell, back in the 50s, I believe it was, worked with a handful of optometrists to study vision development from infancy up to the ages of 10 or 12. And one of the things that group wrote about way back then, think about that, back in the 50s, they wrote, if you want to understand the child's vision, you have to understand the whole child. And if you want to understand the whole child, you have to understand their vision development. So there seems to be a lot of misconception about that vision therapy is just an eyeball-based activity. It is not. It is a brain-based activity. For example, there are 12 cranial nerves that are direct branches off the brain itself. Major cranial nerves, 12 of them, roughly 2/3 to 3/4 of them are directly tied up in vision. That's a lot of brain space allocated towards vision and vision development. Vision development really is kind of a lifelong process. Something I just reread a few weeks ago said that the beginnings of the optic nerve and the beginnings of the eyeball begins to take shape roughly 2 weeks after conception.
Wow.
2 weeks.
Wow.
And on the same vein, there's something called frontal lobe activity or executive function skills. And I think in some behavioral optometry circles, we might describe frontal lobe activity as visual imagery. Can you visually image the consequences of your actions? Frontal lobe activity or these visualization skills seem to not really fully develop until our early to mid-20s. So we're talking about...
Wow, those are extremes right there. From 2 weeks after conception to our mid to late 20s or early, what did you say, early to mid 20s?
Yes, early to mid 20s.
Oh my goodness. Wow.
Yeah, vision development takes place over quite a long time.
Yeah.
And beyond that, we maintain neuroplasticity in the brain over our lifetime. So we can always make changes to brain-based behavior. I don't care how old you are. I think the oldest patient, this is such a funny story, because I sometimes will tell this story in the office where somebody's contemplating, do they want to do vision therapy? And I say, I had a mother and her daughter come and do vision therapy in my practice maybe a year and a half ago. And people listen to the story, they're like, oh, that's interesting. And I say the daughter was 62. They're like, what?
Changes the whole perspective. That's right. Wow.
Perception is everything.
It is indeed. That's right.
Her mom was in her early 90s.
How about that?
So it's never too late to do vision therapy.
So again, when you say that, I'm chomping at the bit to go, what do we do? What is vision therapy? Like what you were talking about, getting away from a screen. But aren't there software packages that you have where you need to be in front of a screen, and then there's getting out into the world and doing things?
There is. So everybody's different. Everybody's their unique individual. Research studies are nice for global kind of statistics relative to the general population. But at the end of the day, when you're sitting in my chair, your unique needs are your unique needs. So my job is to do a proper assessment to start with, and then come up with a developmentally appropriate plan. When I go back to the comment about the name of this podcast, Move, Look, and Listen, my model, generally speaking, from bottom up, we look at nutritional components of how you're functioning. We look at something called retained primitive reflexes. We look at something called millisecond timing clock deficits and whether they exist in your brain. You know the expression, he is walking to the beat of his own drum?
Mm-hmm.
That's this millisecond timing clock deficit. And it is measurable and it is trainable. And the interesting thing about this millisecond timing clock and the company that has done something about it to measure it and train it, it's called Interactive Metronome. And that was created by a music producer who was also a conductor. And I think he got tired of talking to musicians about their timing and how they were a little bit ahead or behind the beat.
Mm-hmm.
And he created this instrument to measure it and then train them. And it has taken on a whole life of its own.
That's awesome.
It is phenomenal. Awesome. So that's a millisecond timing clock. And that's usually the first stage of my therapies. Nutritional considerations, primitive reflexes, and this millisecond timing clock. So that's stage one for me personally.
Mm-hmm.
Then we might move into stage two. Stage two is something called magnocellular vision or motion processing. Your ability to see fast and do it under low contrast conditions, because magnocellular visual skills, if it's not the gateway to attention, it's pretty close. So it is about seeing fast. And my experience and the the literature that I've read over the last 10, 15, 20 years from a variety of different disciplines, cognitive psychology, neuropsychology, social psychology, neurooptometry. When I tell you these things, they're an assimilation of me reading in a lot of different fields and then trying to weave that all together into the model of where I practice currently, because it's very different than when I practiced 20 years ago. And I still learn stuff every day. I added a new therapy to my practice 6 weeks ago called the Safe and Sound Therapy. People can Google that, Safe and Sound Therapy.
We'll put a link in the show notes for that.
Yep. And it fits into my model of what I do now. And there's a magnocellular theory of dyslexia that most of the people listening to this program are going to go, what? I thought dyslexia was just a reading disorder. Well, that's the outcome. It doesn't tell me why you're having difficulty with reading. It doesn't tell me why you're not benefiting from reading instruction that your peers are benefiting from. It's just giving me a label and an outcome, which is not the way to determine a course of therapy. I would say in most cases, if you have a child with a reading disorder or specific learning disability, which typically means a reading disorder, or they even have the label dyslexia, invariably what you're told is you just need to do more reading. I'm not going to be so bold as to tell you that there's not gains to be made if you're doing more reading, because it's kind of like saying, well, if standard instruction is like trickling water into a bucket, over time, you'll fill your bucket up. That's true. But if you got a bucket full of holes, like primitive reflexes, millisecond timing clock problem, magnocellular vision dysfunction, focusing, tracking, and teaming problems, etc., it's like you got a bunch of holes in the bottom of your bucket. Until you even know those holes exist, let alone to have the holes and what they represent assessed, and then put in some sort of developmental hierarchy in terms of treatment strategies, you're completely shooting in the dark.
Right.
So, and if I take that same holy bucket analogy and I stick a fire hose in the bucket, like just doing more reading, I will temporarily fill your bucket up, but not because I plugged up your holes. It's because I poured it in so much.
Gotcha.
But as soon as I stop pouring that fire hose in, what I thought you knew, it leaks right back out.
So vision therapy will help plug the holes.
Vision therapy is designed to help assess how many of those holes you have, what deficits and how big are the deficits, and then let's come up with a developmental plan that makes sense to plug your holes. Because, remember, there's primitive reflexes, millisecond timing clock, nutrition. Then there's magnocellular vision, then eye focusing, eye teaming, eye tracking. That's, in my model, that's stage 2. Stage 3 is really working memory, executive function, rapid naming speed, and phonological processing skills. And then ultimately, if we still need to address it, then there's true reading outcomes and going back and retraining your knowledge of our alphabetic writing system so that you now can benefit from reading instruction in a way that you couldn't benefit from before because we didn't know you had all these problems. I have some kids that it truly is painful to look at print. It's painful. So if I take a kid who's pained by looking at print and simply tell them, and I don't recognize that that's the problem, and I say, oh, well, your eyes hurt after looking at print for 5 minutes. Well, I need you to look at it for 4 hours a day because I need to do this reading tutoring to intervene to up your decoding outcomes. But your eyes hurt after 5 minutes of looking at print. Can you imagine looking at it for 4 hours?
Now, there might be some listening saying, wait, what do you mean that there are people whose eyes hurt after looking at print? Because that sounds like a ludicrous notion to most people. What do you mean your eyes hurt? You have to read every day. How can you even function when your eyes hurt? The way I understand it, Dr. Stephey, is it's more than just, it's almost repellent to some people because of how their brain is processing the way the words look on the paper. So it's not just that my eyes physically hurt like someone stuck a needle in their eye, but it's also there's some anxiety associated with it.
Tim, you're starting to catch on.
It's only taken me 2 years, but I'm getting there. Thankfully, we have this podcast.
There's a term called visual aliasing, and there's a term called visual stress. And visual stress and visual aliasing really are representative of the same outcome, but Their origins are slightly different. And there's a cognitive psychologist in the UK named Arnold Wilkins, Wilkins, Arnold Wilkins, who wrote a book called Visual Stress, and he wrote a book called Reading Through Color. Both are powerful, powerful books. What he talks about is the black and white striped nature of print specifically, and how truly visual repellent it is for some people. You've probably heard the term photoepilepsy, or how some people have seizure activity with certain rates of flicker.
Yes.
Well, fluorescent lighting flickers, and black and white stripes electrically have the potential to do the same thing to the brain that flicker does. And Wilkins created a pattern of black and white stripes that is specifically designed to solicit this kind of a response from you if you are prone to visual aliasing or visual stress response. So you look at this center fixation dot of this pattern of black and white stripes. And my simple question to you initially is this comfortable or uncomfortable to look at?
Right.
That's the first question. So if you're not prone to a visual aliasing or visual stress response, you look at the black and white stripes and you're like, it feels fine. If you are prone to this response, I have some people who can't even look at it for more than about 2 seconds, and they say it's so disturbing to them in their eyes, in their brain, in their ears, jaw, throat, chest, and or gut, that they can't even look at the stripes.
You know, again, that is part of what really attracted me to your practice was you asking me that question during my first visit with you, because I was one of those who does not like looking at the printed paper. And I do not like to physically read. I love to absorb my content through my ears, which is why I started a podcasting network and was in broadcasting for many years. And Audible is a big sponsor of all of the shows on my network. But can you imagine, though, being a student who doesn't have the luxury of absorbing all of their content through their ears? Of course, the teacher speaks, but you have to read your homework or read a book or do something that requires the visual component. And that is why what you're saying is so paramount to the success of children in particular that are going through school.
Well, I'll give you a couple examples that are relevant to this discussion. One example is a guy who was in his early 50s, who's got a master's degree in social work. And I was telling him this story about the way his two eyes would work together. And a light bulb went off. And he said, "Oh, you want to know how I got through graduate school?" He said, "I couldn't read and comprehend at the same time."
Wow.
So I read my assignments, taped them, and then listened to myself on tape.
Wow. Now, that takes a lot of time to do that.
Think about that.
That takes a lot of time. So think about, had he perhaps had the opportunity to experience vision therapy at a younger age, how much time and how much easier would it have been for him to obtain his master's degree without having to go through that extra time arduous step?
I had an optometrist come visit me in 2008. She was finishing a vision therapy residency. She came to see me about 11 months into a 12-month residency. And during the course of my assessment with her, because she didn't like this grid that I'm alluding to. And when she saw me pull out this grid, she said, "You know, I'm probably not going to do very good at this either." And I said, "What do you mean?" And in the span of about 30 seconds, she said, "Well, I don't really like to read." And then she said, "That's not really true. I hate reading."
Yeah.
And then she said, "I'd rather cut my fingers off than read." That's how painful reading is to her.
It's a real thing, folks. I know there are a lot of people that just don't get it because they love to read. Like my wife loves to actually hold a physical book with paper and read. I'm not talking like on the Kindle or something. Like she just loves the process, and I can't think of anything more repellent. And that's the truth. And so I get it. It's a real thing. And Dr. Stephey, we're running out of time on this episode right here, but it really is a perfect prelude episode to what we have coming up in our next episode.
One final comment I want to make.
Please.
Vision therapy is a pretty broad umbrella, and there's lots of pieces that can come underneath it. And you could have had vision therapy elsewhere and still have a vision therapy problem. Because if we haven't comprehensively looked at all the pieces of this puzzle, it means that maybe all of your vision therapy diagnoses didn't get treated. Maybe some of them never even got assessed to be treated. And maybe the things that got treated worked when you did the therapy, but maybe 6 to 9 to 12 months passed, and you come and find me by the web or word of mouth or a school district referral, and I measure skills that purportedly were fine 6 or 9 or 12 months ago, and now it seems like you've lost those skills altogether. I think those might be examples of why, in some circles, the perception is that vision therapy doesn't work. My experience would say that you didn't get fully assessed, and you didn't get fully treated, and you didn't get treated in the right developmental sequence. Because, for example, I won't do eye teaming and eye focusing therapy in my office if you've got a millisecond timing clock deficit, or you've got retained primitive reflexes, or you got a magnocellular vision problem. Because my experience has been over the years that if I try to do eye teaming, eye focusing therapy without knowing those other lower level developmental skills, it's going to take me longer to treat those deficits to start with, and they're likely not going to stick as well. My model is like a house of cards. If you got a shaky foundation to start with, which is primitive reflexes, nutrition, millisecond timing clock deficits, if you got a shaky foundation, the second and the third foundation up is built on shaky ground. So I want to start from the ground floor up. You may not necessarily like all the things that I'm going to tell you, but you'll appreciate the depth of what you'll learn, and you'll know the sequence of what should happen. You'll know the depth of what's happening with you or your child, and you'll have a much fuller understanding of the work that lies ahead of you, and that you know that there's a path that this can work. And that's the most significant thing for me at the end of the day. At the end of the day, you are the judge and jury of whether or not you accept my findings and the knowledge that I have to share. No one's ever accused me of not sharing enough information. You want literature on primitive reflexes? I will send it to you. You want magnocellular vision and the theory of dyslexia? Got it covered. You want things about convergence insufficiency and eye teaming, eye focusing? I'll send you a couple links. I'll send you some articles. You want millisecond timing clock deficits and how it affects our abilities across the board? Got you covered. So be careful what you ask for when you come and see me, because it is a red pill, blue pill moment from the Matrix. There's no, if you take the time to listen to me, there's no going back. It is going to change the course of how you think about life and what your needs might be and what your kids' needs might be.
I was intrigued from the moment I met you. It's the truth. And it was about 2 years ago, and I'm so thrilled to help get this information out, because so many lives can be changed with what you're doing. I really believe that with all my heart and soul. And like I said a few moments ago, and I'd love for you to kind of tease what our next episode is, because all of this is so incredibly relevant to what we're about to talk about.
In our next episode, I'm going to try to dive a little deeper into how to connect vision therapy with your kids' special education needs and what their educational rights are, and how we can advocate with you and for you so that you have more power in your corner, so that you can have more power in your corner and be a more effective advocate for your child and their needs.
Thank you for listening to the Move, Look, and Listen podcast with Dr. Doug Stephey, brought to you by Audible. Get a free audiobook download and a 30-day free trial Audible membership at audibletrial.com/inbound. You'll find over 180,000 titles to choose from, including books mentioned here in the Move, Look, and Listen podcast. You can listen to these books through your iPhone, your Android, your Kindle, your computer, or even an MP3 player. And if for any reason and at any time you choose to cancel your membership, you keep all of your audiobook downloads. Give it a shot for 30 days. You got nothing to lose. Support the Move, Look, and Listen podcast by visiting audibletrial.com/inbound. We will include a link for your convenience in the show notes of this and every episode of the podcast. And of course, if you'd like some more information regarding Dr. Stephey's practice or to make an appointment, we will include links in the show notes to Dr. Stephey's website and his YouTube channel. Dr. Stephey's website is stepheyoptometry.com. That's STEPHEY optometry.com. You can also call the office at 626-332-4510. Again, all of Dr. Stephey's contact information will be included in the show notes of each and every episode. One last request before we let you go on to the next episode. Please subscribe to the podcast from whichever platform you might be listening in. Of course, it is free to subscribe, and it ensures that every time we post a new episode, you'll find it right there waiting for you to listen in your podcast app of choice. We really do appreciate you listening. And until next time, for Dr. Stephey of the Move, Look, and Listen podcast, I'm Tim Edwards with the Inbound Podcasting Network.